Well, ladies and gentlemen, you have all seen that we have used considerable amounts of drug in this trial, and the question is really, how much did we need to spend money-wise, and did it pay off at the end of the year of treatment? So it's not only about financial cost, though, inflammatory bowel disease. When we think about inflammatory bowel disease, the disease has an impact on the personal quality of life, on physical well-being, concerns for family related to pregnancy, for instance, psychological well-being, expectations for the future. So basically, of the cumulative burden of IBD on a patient, the finances is only like one aspect of a whole range, so we have to keep that always in mind. So if we now think theoretically what the potential benefits could be of optimal use of the available treatments when we apply a treat-to-target approach in IBD, but mainly in Crohn's disease, which is the topic of this symposium, well, achieving sustained deep remission is definitely of value to the patient. We know that. And that probably is accompanied by a reduction of intestinal damage, like Dr. Prianta has shown, reduced complications and reduced disability. And that then secondarily leads to a reduced need for surgery. Extraintestinal manifestations will disappear. And as we've seen in 25% of the patients, we were able to withdraw treatment, or at least one of the treatments, to a certain extent. In children, it is very important, children and adolescents, to restore normal growth, so that's an important aspect. For adults, it's important to be able to go back to work and have a normal social functioning. And when I saw this slide, I added one box here at the end of the slide, which I think should be the ultimate goal in our IBD management, which is return to normal life. That really should be the eventual goal, okay? So we've just seen the trial and the data of the trial, and you've seen that symptomatic and endoscopic remission was reached more frequently when a tight control approach was used compared to conventional clinical management. And tight control was based on symptoms plus two biomarkers that we all use in our clinic, C-reactive protein and fecal calprotectin, and that led to an increased use of adalimumab in the tight control group. But you've also seen that more intensive immunosuppression, more adalimumab, more azathioprine, did not result in increased toxicity signals, at least during the year of the trial was performed. And here we're just looking at the serious infections, and you will immediately appreciate that, for instance, for perianal abscess, that was a bit counterintuitive, was even more frequently seen in patients that were in the conventional clinical management group, 4 abscesses versus 0 abscesses in the patients who were in the tight control group. And all the other infections occurred like equally frequently, even a bit more frequently in the clinical management group than in the tight control group. There was one sepsis in the clinical management group, being the most severe infection that we observed here. So let's now look at a number of other outcomes that are very important to the patient and that you haven't seen in the previous presentation. And those events occurred in the first 48 weeks, the duration of the trial, and were very important when we think about cost, okay? There were Crohn's disease-related hospitalization, and the definition was any overnight stay in the hospital that was related to Crohn's disease up to 70 days after the last dose that adalimumab was given in this trial. Then you have surgeries. Crohn's disease-related surgical procedures that we split up into 2 categories: the major Crohn's disease intervention, resections, stomas, stricturoplasty, or drainage of abdominal abscesses. Then the non-major, you could also say minor Crohn's disease-related surgeries were abscess drainage, set-on placement, fistulotomy, or placement of a TPN access line. Okay. Then the adverse outcomes were pooled in a third endpoint: Crohn's disease-related hospitalization or serious complications, basically a pooling of all serious adverse outcome, and then also time to Crohn's disease-related flare a flare being defined as an increase in the CDI score of at least 70 points from 1 week prior to randomization, and a total CDI score above 220, so clearly representing active disease. So looking at the hospitalizations, and Dr. Panaccione showed this at one of the sessions earlier today, you immediately see there was a clear difference. There were much fewer hospitalizations in the tight control group, 14 hospitalizations versus more than double, 29 hospitalizations in the conventional management group, and that was clearly highly statistically significant, okay? What about Crohn's disease-related hospitalizations due to an emergency? Patients came through the ER in the hospital. You see that the difference was not statistically significant, probably because there were too few events for emergency hospitalizations in the tight control group versus 11 hospitalizations in the clinical management group, so numerically quite significant. What about the incidence of the Crohn's disease-related hospitalization or serious complications, so the pooling of the important adverse outcomes, okay? In the tight control, 14.8% of the patients. In the clinical management, 20.5% of the patients. Again, not statistically different, but numerically there is clearly a trend here, okay? What about the Crohn's disease-related surgical procedures? And think of it, we're only looking at the patients for a year, which is kind of short in the disease history of a Crohn's disease patient. But nonetheless, fewer events in the tight control group, 7 surgeries, 9 surgeries in the clinical management group. And then the time to Crohn's disease-related hospitalization or serious complications, so the pooling of the adverse outcomes, no significant difference, but a numerical longer time to a severe adverse outcome in the tight control group. The same is true for Crohn's disease flare, but here we do see quite a statistical advantage in favor of the tight control group, much fewer, much later relapses of the Crohn's disease compared to the tight control group. Okay? Now, I've alluded to the 1 year that this trial may perhaps have been a bit short. And we typically do 1-year trials in Crohn's disease. It's been exceptional that trials lasted longer, and so I'm very much in admiration for the Geert group that they launched on a 5-year trial, which is really exceptional when you think of the wildest results that may come forward from that type of approach. But we did one other trial that we followed patients for 2 years, the REACT-1 trial. Benjamin alluded to the REACT-2 trial, which is endoscopy-driven, but the REACT-1 trial was driven by symptoms. So here we looked at patients with Crohn's disease that were followed in 2 groups of IBD centers. And one group of IBD centers treated the patients by their usual care. And the other group of IBD centers, another cluster, it was a cluster randomization trial, saw the patients back every 3 months, and when they were not in clinical remission, the treatment was escalated. So no endoscopies, no biomarkers, just by clinical outcomes, CDAI, and the treatment was escalated from adalimumab to weekly adalimumab to another antimetabolite, switch to TNF antagonist, and then finally consider resection. So really a build-up at every 12-week visits, basically, until the patient was really in remission, which was the goal of the trial. And what we observed here, and you must have seen, or perhaps you've seen the publication in the Lancet already 2 years ago, that in the first year of follow-up, we did not see a difference in any adverse outcomes. For instance, hospitalization, surgery, or serious disease-related complication, no difference in the first year. Fortunately, at the beginning of the trial, we decided that this needed to be a 2-year trial. So we followed the patients for another extra year, and what became clear that in the second year, the curves clearly separated in favor of the rapid treatment escalation based on symptoms. So imagine what will happen now in REACT-2 when we decide to escalate treatment based on endoscopy. So most likely we'll have much more separation of the curves. I'm really thrilled to seeing the data, but I'm afraid it's going to be another year or two before we have those data. So now I'm going to take you to something really difficult, an economic model. We are doctors, we don't think too much about money, I hope, but this is now a pharmacoeconomic analysis based on the CALM data, and it's quite interesting what we see in terms of outcome here. So at any point in time, the patients were categorized by their disease state based on the CDAI. They were either in remission, or they had moderate disease activity, severe disease activity, or very severe disease activity. And all those disease states are associated, and we know that from previous models and publications, with a certain quality of life based on the EQ5D. And we know that certain levels of EQ5D are associated with healthcare utilization. Because when you don't feel well, you go to the doctor, or you have a test, or your culture, or an endoscopy. So that cost comes along a lower EQ5D or a lower quality of life. At any point in time also, as I showed, you could be hospitalized. Hospitalizations is extremely expensive in the United States. It's also expensive in Europe. But anyway, that's a major driver of expense in healthcare utilization. Okay? So now we have to calculate something that is very difficult to understand, but it's the incremental cost effectiveness ratio. What does our intervention bring along in terms of higher cost? But what do we win in terms of improved quality of life, which is then reflected in something that you will recognize, quality adjusted life years. So here to the right of the slide is what we gain by the investment that we make on the left side on the slide, okay? And so what we win in terms of quality of life is again based on the CDAI, on the EQ5D that is associated with that, and on the reduced cost of those disease states. So what were the direct medical costs that we calculated in this model? Evidently, the cost of hospitalization, and there is a standard cost for that. This is a United Kingdom model because there is most of the numbers and the models are based on UK data, so that's the easiest to apply. So what we did, we looked at the hospitalization rate in the CALM trial, and we multiplied that by the standard hospitalization cost for Crohn's disease in the United Kingdom. Cost of adalimumab was easy to calculate. You know how many syringes were consumed and the patient injected, so we counted the injections in the different treatment arms by the list price of adalimumab in the United Kingdom. That was easy to calculate. And then you have other medical costs which are associated with the reduction in the EQ5D, in the quality of life, associated with certain disease state measured by the CDAI that we had available from the CALM data set, basically. And so bringing the costs then together with the quality of life that we win, that gives you this calculation, the incremental cost effectiveness ratio of what you do in terms of intervention. So looking at costs here immediately, then we see that the patients were much more likely or much more frequently in remission, 62% of the time in the tight control arm versus 47% of the time in the clinical management arm. That's associated with reduced quality of life, and so with a higher healthcare utilization, okay? The Crohn's disease-related hospitalizations, we've seen that data that was observed in 13 events per person year in the tight control, 28 events per person in the clinical management group. Adalimumab, as I said, on average in the tight control group, patients received 31 injections of adalimumab in the whole trial, in the whole year, okay? Versus 25. It's very difficult to inject 24.7 syringes, so let's say 25 syringes in the clinical management in the duration of that year. And here's the cost of adalimumab at the bottom in the tight control, on average 10,870 UK pounds versus 8,705 UK pounds in the clinical management, okay? So evidently, direct medical costs were lower in the tight control group, almost 1,300 UK pounds versus 1,500 in the clinical management, and also the hospitalization cost was reduced from 2,400 almost in the clinical management to 1,100 or so UK pounds in the patients on the tight control. So you're beginning to see the picture There are more drug costs in the tight control group, but there are many more hospitalization costs and other direct medical costs in the clinical management group. And so bringing that together in this model and in the numbers, and now you have to think you live in the UK because we're looking at pounds here, UK pounds. So total direct medical costs, the sum of the individual items that I've explained you, were 13,000 UK pounds in the tight control group, okay, and 12,600 in the clinical management group, which was a delta of 669 UK pounds that the tight control was more expensive. Not only for drug, but also for additional tests that we performed in the trial. What did we win? What were the quality adjusted life years? Okay, so here reflected in the QALYs in the tight control, 1.684 in the tight control group, 1.652 in the clinical management group. You may think this is not a big difference, but think of it. When you multiply that across the whole patient population, it really did make a difference. And if you calculate the cost to gain one QALY, okay, across the intervention, it was around, well, 21,000 UK pounds, which, according to the NICE guidelines in the UK, is a highly cost-effective intervention, because once you're under 30,000 UK pounds per QALY, then it's considered to be a cost-effective intervention. So I hope I made this very complicated story comprehensible, but that's how pharmacoeconomists think, and I hope you can think along. So in conclusion, ladies and gentlemen, I think that tight control in a CALM trial in patients with Crohn's disease led to improved outcomes. We understand that better than money, improved clinical outcomes, reduced hospitalizations, and improved quality of life, but also that the treat-to-target strategy was cost-effective compared with clinical management based on an UK economic model using the CALM data. And with that, I thank you for your kind attention.